Hello and welcome to Rad Chat. We're here live at the SGRT Community Conference. So we're joined by our final guests of the day. Save the best till last. Is that a phrase you're familiar with? So would you mind both introducing yourself, please?
Okay, my name is Igor and Bessières. I'm a medical physicist. I'm from France, from Dijon. So it's a city in Burgundy. And my colleague Mathieu.
Hello, I'm Mathieu Gonod. I'm a medical physicist too in the same city, in the Centre Georges-François Leclerc. And we are working about the Vision RT system.
We're both working on and studying, investigating Vision RT products.
How amazing that you both work at the same centre. They must be very lucky to have you both there.
Yeah. I think they love working with us, and
you hope.
We hope. And sometimes we try also to push Vision RT teams to do better and to improve their products. So
yeah,
this is a kind of a game between them and us.
Perfect. Well, that's how it should be, shouldn't it? Really. So, can you tell us a little bit about kind of what you were presenting on today?
So on my side, actually we were both presenting on the MapRT product, and on my side it was more about the evaluation of the accuracy of the system. So I don't know if everybody's familiar.
Tell us about
MapRT.
that.
So MapRT so as all the product from Vision RT, the product are based on the 3D surface imaging. And specifically, the MapRT products is dedicated to the prediction of collision between the treatment devices and the patient. So the idea is to be able to predict any collision, to avoid any collision, of course. But the second another use of MapRT is try to use it to improve treatment by using non-co-planar treatments, complexify the treatments. So I presented this study on the accuracy of MapRT, and Mathieu more on the complexification of the treatment.
Because at this moment we are more and more concerned, and we are increasing the complexity of treatments. And MapRT is a tool that can facilitate the integration of complex beam configuration. And so I present how to use on standard treatments, how this tool can change the standard treatment, because his new information is more how to say.
It helps to securize and to optimize the treatment, to complexify it safely.
Yeah.
The treatment. And what Mathieu presented today is that we succeed in reducing the dose to the organoids while having the same coverage to the target and to the tumor, and without any huge additional time of treatment. So the quality of the treatment is improved without any and keeping the same level of security on delivering the treatment safely.
So you mentioned about accuracy evaluation.
Yeah.
How would you even go about that?
So you mean how we did this study? So the idea is that MapRT is predicting and saying, okay, if you make this combination of rotation of the machine and of the linac and of the couch, and if you put the patient in this position, you will have a collision. So the idea is just to compare if we apply this collision on the system, we really have the collision or not, and just evaluate the rate of prediction of the MapRT so on MapRT you can add a buffer, so it's kind of a margin around the patient and around the couch, and the idea is just to fix this buffer value and make sure that prediction rate is about 100%.
Yeah.
So we investigated the size of this buffer in order to make sure that this tool is reliable.
And it was.
It is. It is with let's give a number with 3 centimeters of this margin, this buffer around the patient and the couch.
And Mathieu, you talked about dynamic trajectory radiation therapy. Something I think a lot of people were just trying to figure out what it is. Can you try and explain that to us, please?
Yes, actually, in the treatment planning, we are including the gantry rotation to have more point of view of the tumor and to have a better sparing of organ at rest. And the future will be to increase this number of point of view of the tumor by including the couch rotation at the same time. And at this moment it's not possible on the machine, but from 1.5 years there's any papers, scientific literature on the subject that are including the gantry and the couch rotation at the same time, and this will allow a better improvement on DVH, on toxicities to the patient. And without a tool as MapRT, it's not possible to securize this kind of treatment.
So if there's more floor angles, would it take longer to do the treatment?
More anger and so more point of view and less sparing.
Yeah, probably longer treatments. So, yes, today, nowadays we have dynamic treatment on the gantry, on the dose rate also is dynamic. The MLC we have, but the couch is not working today. So the idea is to have also a dynamic couch. It will. I mean, the paper shows a really great improvement on the DVH, but the big question is how can we safely perform this kind of treatment? And without tools including this kind of clearance map, it's not possible to generate this kind of treatment. So MapRT is mandatory for this kind of improvement, this kind of new techniques.
When you say the dose rate is also dynamic, does that mean at different points it would be higher or lower? Or?
Yeah, exactly. The dose rate is changing according to this is the result of the optimization of planning. So depending on the index, the dose rate can also change.
So would that be during treatment? I'm just trying to explain,
Yeah.
I suppose, explain to people who might not know why a dose rate should change. Would there be certain aspects of a treatment where you want it higher or lower?
Yeah, depending on the angle of irradiations and depending if there is organ at risk on the trajectory, to maybe the dose rate, the system and the result of the optimization of the treatment suggests higher dose rate or lower dose rate.
It'll be interesting to see how this then links with radiobiology and specifically then partners with potentially doing greater doses, thinking about dose escalation. Is that something that you envisage in the future if this becomes something that becomes standardization?
You mean the escalation of dose? Yeah, of course. The today what limits the dose escalation is the organ at risk. If we have more degree of freedom to irradiate the patient thanks maybe to dynamic couch, we can imagine that we could increase the dose to the target and have a better compromise between the sparing of the organ at risk and the coverage of the PT.
It's exciting times.
Yeah.
Our surgeons are going to be obsolete.
I don't know. I don't want to answer this question. But the idea, everybody try to improve his field. So this is also why radiotherapy is exciting.
Yeah, and obviously thinking about the patient and lessening side effects is going to optimise from our perspective, especially as therapeutic radiographers in supporting patients with living better for longer. So in terms of kind of the future, what plans have you both got? Heavily looking at research, is there anything that you want to do in the future or take forward?
We have a lot to do. We have a lot of projects, not only with Vision RT, but we are working also on detectors, protein detectors. Mathieu is working on scintillators. We also have MR-Linacs in our hospital, so Vision-RT is not...
Oh, now you're showing off.
Yeah, we have a lot to do, but this is, as I told, this is what is exciting in radiotherapy, that we have each year new techniques and changing the paradigms. Not each year, but maybe each 10 years or 5 years, there is something really new that make the research really exciting.
And Mathieu, what do you hope will happen in the next few years?
That depends on which subject. But for radiotherapy, I think dynamic radiation therapy will come in 5 years, and perhaps I don't know for future, but depending of vendors. So.
Brilliant. Well, thank you so much for joining us on Rad Chat, and we look forward to future publications and advances in radiation oncology. So
thank you very much.
Cheers.